Hello, everyone, again. Thanks for these technical problems. Probably is a sign that there are more than 1,000 registered in this webinar. And thanks for watching. And this is the second series of the webinars of the Portuguese Society of Internal Medicine, namely is ultrasound study group of the Portuguese Society of Internal Medicine. We did the first webinar just about 5 weeks ago, and this is like a tremendous amounts of information that have passed through about ultrasound and all the things around the treatment and the orientation of patients with COVID-19. And thanks to the Portuguese Society of Internal Medicine, that in the last weeks, with a huge work dynamizing all the study groups in the society, trying to give as much as possible solid information from every aspect of the treatment and the evaluation of COVID-19 patients. And to Fujifilm Sonosite, which is a sponsor, the major sponsor of these webinars. And I have deeply to thanks to Sonosite for supporting us. And of course, to thanks all the commitment of my guests. And some of them are the same of the first webinars. And in the third part, next Saturday, we will see almost the same fighters. And today we'll have my friend and mentor and a huge personality on international point-of-care ultrasound, Dr. Michael Blaivas from the United States, and he will focus on the recent advances of the research and what is being done around the ultrasound for COVID-19 patients and what are the main challenge for the future. And then we'll have again also Jorge Teixeira, the director of the emergency department of the Hospital de Braga in Portugal, and also my boss. I have to be very careful in this webinar. And he will frame the COVID-19 pandemics in real numbers from our emergency department, the place where I work, and to better put in context the problem of the application of ultrasound and all the complementary exams of radiology. And then I have to deeply thanks to Monica Diniz, radiologist from Algarve, Faro, and she is the board member of the Portuguese Society of Radiology, Neuroradiology and Nuclear Medicine. And I have to deeply thanks to embrace this initiative and to being as an expert of for radiology, to give us the evidence of what is the role of mainly the CT scan and the X-ray, thoracic X-ray in the evaluation of patients with COVID-19 or suspected of being infected with the new coronavirus. And this is a topic I will have to briefly highlight. In the 2nd of May, we were planning as the study group of ultrasound to do our first meeting. And the first meeting was to be named the consensus. And we want to join all the colleagues, enthusiasts in the point-of-care ultrasound, and also radiologists to discuss what will be the roles and the limits of point-of-care ultrasound, mainly in internal medicine, but to be also discussed in a more broad categorization in general medicine. And I know that for her it's like a huge responsibility to represent a society of radiology and to discuss with non-radiologists. But I think this is the one thing to highlight, because it's with the discussion, collaboration, and to meeting the real experts on ultrasound and the other ways of making diagnosis and orienting patients with imaging, with image, and I have to thanks she's being with us and to share her knowledge. And I think this will be the first steps to a fruitful collaboration in the future. Now, with all these delays, we will start with Dr. Jorge, then we will have the presentation of Dr. Michael Blivas, and then Dr. Monica Diniz. At the end, the people who's watching could participate in our chat and can put questions that you have to our presentations, and we will answer as soon as possible and what will be possible. We'll have like a small questions and quiz that you could answer by your computer, and please feel free to participate at the end at the discussion that we'll have together at the end. And now, thank you again. Thank you for these small technical problems, but this is the way of webinars, and please stay at the end for the discussion. And thanks, and see you.
Hi everybody, I am going to make a small presentation about how we cope and adjust to COVID pandemics in an emergency department in Braga. I am going to show to you our activity indicators, performance indicators, quality indicators, cost indicators. You can see in our accumulated activity to April, a decrease in 23% compared with last year. Concerning our triage priority levels, we lost patients in every level of priority. We divide our emergency department in 3 types: adults, obstetrics and pediatrics. The department lost around a quarter of patients, and pediatrics lost 32%. The average number of patients per day decreased abruptly in the middle of March, the beginning of the pandemic in Portugal, from around 600 in February to 270 in April. As I said before, patients lost were from all triage grades. There was a decrease of 21% in very urgent, 25% in urgent, and 25% in less urgent. If we look at the adults, there was a more significant decrease in less urgent triage level. The average loss of patients was 22%. In obstetric patients, the decrease was 20%, with a more significant decrease in March and April. In pediatrics, the decrease was more severe, with an average of 140 patients in January, to 28 patients in April. All level of triage had great loss. COVID-19 was tested in 500 patients in March and 3 times more in March. The positivity rate was 19%, and in the 8th of April %. The hospital mortality raised 12%, with a 10% reduction in ED, 24% increase in inpatients. The triage waiting time reduced to more than 50%, because we lost more than 50% of the patients. The time to medical observation reduced. We have 2 clinical decision units for more serious patients. The CDU1, before March 15, CDU for urgent and less urgent patients, became COVID CDU. The CDU2 is non-COVID unit, before CDU for very urgent patients. The waiting time in ambulatory and trauma minor decreased about 50%. Let's talk a little about our performance indicators. 5% of our budget is dependent of these indicators. The first is the percent of low-grade level. As you can see, it raised after the pandemic. The second died. The percent of patients admitted, it raised from 9% to 14.7%. The third is the percent of patients observed in the expected triage time. The indicator is improving because of low affluence, and it's now 89%. The level of achievement is greater, as expected, in less urgent patients, because the time to observe patients is much more. The fourth performance indicator is number of frequent users of ED, is now improving. The fifth performance indicator is the rate of accessibility, measured by the rate of external consultation emergency episodes. The length of stay improved. In April, the length of stay for patients with lab and radiology exams was about 5 hours. In this slide, we can see the relation between the type of radiology exam and length of stay. CT and ultrasound were associated with increase in length of stay in 1 to 3 hours. The abandonment rate was very low, because in Portugal is associated with waiting time to medical observation. The rate of patients with length of stay of more than 6 hours decrease 8%. The number of complementary mean of diagnosis per patient increased in laboratory and radiology. Complementary mean of diagnosis in the laboratory increased a little per patient. Complementary mean of diagnosis in radiology CT increased 3% in the 4 months period, and 7% in April. Ultrasound and X-ray maintained per patient. CT per patient increased especially in body CT, 1.5% in the 4-month period, and 4% in April, from 6 to 10%. Let's look now for quality indicators. The complaints improved a lot, because the waiting time for medical observation was reduced. This is the first cause for complaints in our hospital. Looking for costs in emergency department, the medical cost for consumables increased about 5 times from €4.20 to €22. This cost more than 5 times our per patient budget was due to the price of personal protective equipment. The pharmacy costs didn't change. The COVID pandemic in our institution was not very stressful, because we are used to have large hundreds of patients per day, and the 50% reduction induced by fear allowed us to plan and execute the necessary changes, separating COVID and non-COVID patients.
Hello and good evening from Lisbon. Thank you for attending this webinar. My name is Mike Blibus. I'm an emergency physician. I've been involved with point-of-care ultrasound since about 1993 and have been quite interested in point-of-care ultrasound research, education, product development, as well as policy creation and working with various cross-specialty efforts for point-of-care ultrasound. Today I'm going to talk about the latest on ultrasound and COVID-19, just to catch everyone up on what may be happening, and this will obviously just be a sampling. I do have one important disclosure, and that's Ekonos. I am a part-time chief medical officer for this company, so keep that in mind as it could be relevant. I'm going to have several objectives today. I want to discuss the latest COVID-19 and ultrasound developments, discuss the quality of the data published on lung ultrasound for COVID-19 so far, and hopefully help you to understand the limitations of the current literature and why they exist, and also understand future research needs to fight COVID-19. There are about 40 studies published so far. This is very approximate because that number is changing daily. In fact, several appeared on Medline yesterday when I reviewed in the evening. Two experiences that I have suggesting even more are coming is that I'm an editor for 2 different journals, and for one, there are probably 15 articles I know of that have been submitted, are in press, under review, etc. For the other one, probably about 10. My guess is then there are hundreds worldwide with different journals. Many are simply in press, have not quite been published yet, but will be arriving soon. This is unprecedented manuscript activity, at least in the last 30 years that I know of. I'm sure probably ever, most likely, given that electronic submission wasn't even possible 20 years ago in most cases. We have a lot of people rushing to publish, And this occurs from both sides, both on the editorial side or the editor side and the production side, as well as on the author and researcher side. Remember, one of the first studies we talked about at the first seminar or webinar is this one. This was an early one out of China. They looked at approximately 20 patients, compared them to CT, documented some of the initial findings, and this was a really great start to research efforts for COVID-19. And let's see how things have progressed. In general, I think there are 4 classes of manuscripts that I'll try to briefly cover. Prospective or retrospective data reports on lung ultrasound versus CT, or versus patient outcome, and possibly just compared to patient presentation. There is the classic review of others' work, or review articles. They can be very important. And then articles that suggest protocols or different approaches, and some additional POCUS uses for COVID-19, which I think is also very important. Here's an example of the prospective or retrospective data. This is a retrospective study that comes out of China, and but it's very well structured, presented on the surface. There's no mention of patient numbers in the abstract, and this is always a little bit worrisome. I think just the abstract is so packed full of information, they probably reached a word limit. But they describe lung ultrasound lesions, findings, distribution, but find a relatively poor correlation to CT scans. In fact, the kappa is 0.5, which is quite bad. Then it's revealed that only 30 patients were actually enrolled. Obviously, this is a step up from the prior study, but this is a very small number of patients to draw any conclusions from. However, the authors felt ultrasound was useful, especially in more critically ill patients, to kind of evaluate them and stage them. But really, there's no data presented other than a scoring system on the impact of ultrasound. This is a popular category. In fact, some of the best cited articles so far are suggestions of various protocols. This is one of them. It came out fairly early. I think the earlier studies have largely come out of Italy and China, because these are the areas unfortunately devastated by this pandemic early on, and perhaps the hardest, at least initially. This is a detailed outline by the authors of their protocol. There's a suggested scoring system and kind of a call to contribute data to them for their effort. There's no actual data presented, but this is very useful for really a call to arms to gather data, analyze it, and try to come up with something useful for the next wave of COVID-19. An example of reviews of other people's work are manuscripts like this. This is a manuscript that looks at COVID-19 lung ultrasound in the emergency department. It's interesting. They use kind of a neat name, CLUE protocol, outline it quite nicely here. The only trouble is the CLUE protocol is a name already used for a very popular internal medicine rapid decision kind of evaluation with ultrasound. Involves a little bit of the lungs and heart. So this isn't really helpful, as it could cause confusion. Otherwise, it's a great idea to create protocols like this. Obviously, the next step is they really need to be tested and validated, but the authors go through how to scan, where to scan, etc. Now, if you're a lung ultrasound expert, you may scoff at things like this, or a POCUS expert, but remember, there are many people reading these journal articles that don't know anything about ultrasound, or are only open to it but don't use it. So this can disseminate information and suggest ways to approach patients so that more people will adopt ultrasound. There are other interesting study classes, the relevant non-lung ultrasound studies, and I think they can be quite helpful. And it's important not to forget that ultrasound can be used in other COVID-19 manifestations, and that there are manifestations that are other than lung related. And this is one that looks at the incidence of venous thromboembolism in hospitalized patients. And it's particularly relevant because of the high prevalence despite prophylaxis, especially seen in the ICU population. And this is a good time to recall that point-of-care ultrasound is perfect for evaluating these patients in the ICU, on the wards, in the emergency department. It's accurate for lower extremity DVT, rapidly performed, and can be repeated anytime without negatively impacting the schedules of traditional consultative imaging providers like vascular labs or radiologists, and will be just as accurate as they will be, but in a much shorter amount of time and much more safely in COVID patients, since they don't have to be transferred then or transported. Other relevant studies include cardiac-related findings. This is a patient that had myocarditis, was found to have quite a low ejection fraction despite being young and healthy. And this isn't out yet, but it's a report of 2 patients that were relatively healthy, had bilateral COVID-19 pneumonia found, should have had normal hearts but didn't. One of them had an elevated troponin, perhaps both, I can't recall now, but this is consistent with myocarditis. And it's a reminder for people to look outside of the lungs with POCUS in COVID-19 patients. Sometimes we can forget this. It's actually a good reminder anytime, but when you're getting low ejection fractions like this, and especially with the fact that several handheld units now allow this, I believe, around the world. So if you're not comfortable judging visually what the ejection fraction should be, it'll calculate it for you with pretty good accuracy using standard approaches. So don't forget about looking at the IVC in these patients as well, obviously possibly for DVTs, etc. Very exciting. Now, to borrow a little bit from Dr. George's presentation, it's important to realize that hospitals are under stress and radiology departments are under stress. Lengths of stay are going up. So anything we can do to improve efficiency would be helpful, and ultrasound is probably the key to that, bedside ultrasound. And to do that, we're still missing certain types of studies. These are prospective lung ultrasound studies with large numbers. And even if they're retrospective, I think they can still be done well. But we need larger numbers, not 20, not 30. We probably need in the hundreds. Ideally, there'll be comparisons to CT for sensitivity and specificity. But we know that the utility of lung ultrasound does not simply lie in correlation with CT, because unlike consultative services that simply report findings on a CT, we integrate lung ultrasound findings in our clinical decision making, and thus ultrasound is much more robust in our hands than simply a CT report without clinical correlation. And this is the beauty of point-of-care ultrasound, scanning your own patient at his or her bedside. We could really benefit from correlations between findings and outcomes, and the ability to triage patients effectively, stage the likelihood of deterioration, and improve efficiency of care. We're unlikely to move forward towards broader acceptance without studies like these coming out. Obviously, it's going to take time. If you think about it, so much has been published already, but yet some of the impact of COVID was only felt in February and March around the world. And normally it takes months to get studies together, get them approved, get them written up, get them through journals. So this is an incredible time of dissemination of information about point-of-care ultrasound and COVID-19, and people are doing a great job submitting articles, even if they're small review articles, just suggestions. It's generating interest, and it's all designed to help people, even if the numbers are smaller than we would like, or there aren't definitive studies showing how scoring helps, staging helps. All of this will be coming. We're just seeing the first initial glimpses. So in summary, we really need good data. We need large data sets. Retrospective is fine and likely to be the best option in many cases, especially with COVID waning for now around the world in many locations. We need validation of a scoring system and proof that we can effectively triage patients, stage their severity, and also prove the true efficiency of point-of-care ultrasound in the care of these patients that many of us inherently know, but we really need to present evidence for broader adoption. Thank you very much for attending this webinar, and I hope you all stay safe and use point-of-care ultrasound for the benefit of your patients, not just in COVID-19, but long after. Thank you.
Good afternoon. My name is Mónica Diniz. I'm a radiologist practicing in Portugal, in Faro. I would like to thank Dr. Maris for endorsing my participation on behalf of the Portuguese Internal Medicine Society in this webinar. I have no disclaimers. This lecture is a compilation of scientific papers on COVID-19 CT as well as personal experience conveyed by doctors, mainly but not exclusively radiologists, battling in the trenches. During this lecture, I will try to focus on the following aspects: the lung CT basic interpretation, the typical features of COVID-19 and differential diagnosis, CT patterns of lung changes during the disease course, correlation between the mechanism of SARS-CoV-2 lung infection and imaging findings, as well as the evolving role of chest CT on COVID-19 pneumonia since February to May 2020, structured reporting for chest CT, pitfalls, and final considerations. I use some abbreviations like GGO for grand glass opacity, CST for consolidation, CP for crazy paving, OP for organizing pneumonia. So let's start with lung CT basic interpretation on relevant patterns for COVID-19 pneumonia. Ground glass opacity is partial alveolar filling. We can see that in a CT scan as an hazy increase in lung density with bronchovascular margins still visible. Consolidation is a complete alveolar filling. We can see increase in lung density with bronchovascular margins not visible, and we can see some hair bronchograms. Examples of ground glass opacification and consolidation. To speak about or to understand the crazy paving pattern, I have to remind the basic anatomic unit of pulmonary structure, that is the pulmonary lobule or secondary pulmonary lobule. It's the smallest lung unit that is surrounded by connective tissue septa. It's supplied by terminal bronchiole in the center, parallel by the centrilobular artery, and the veins and lymphatics run in the periphery of the lobule within the interlobular septa. So, there are two lymphatic systems, a central network that runs along the bronchovascular bundle towards the center of the lobule, and a peripheral network located within the interlobular septa and along the pleural linings. So, crazy paving is ground glass opacification with superimposed and intralobular septal thickening. This is a CT scan of a normal lobule. Here, ground glass opacification with thickened interlobular septa, here. And finally, both ground glass opacification in the middle, the thickened of interlobular septa and intralobular septa. Why it's called crazy paving? I think the picture is self-explanatory. Regarding organizing pneumonia pattern, I will only refer to the three patterns that we usually see in COVID-19 pneumonias. Linear opacities, that are band-like opacities with or without hair bronchograms. Reverse halo sign or atoll sign, that are complete or incomplete circle of consolidation surrounding an area of ground glass opacification. It's also called atoll sign because it is very similar to an atoll. And perilobular opacities are densities that follow the periphery of secondary lobule. Here they are. Regarding anatomic location of lesions in the lung in the axial plane, we can classify them in predominantly peripheric or central, or peripheral and central. They are peripheric if they affect the lateral portion of lung, the third lateral portion. They are central if they affect medial lung, the inner part of lung, or have a bronchocentric pattern. And finally, they are peripheral and central if they affect lateral and medial lung or have no predominance. Let's move on to COVID-19 pneumonia typical features and differential diagnosis. By now, I suppose that everybody knows that ground glass opacifications are the most common finding. They are often rounded in morphology. We can also see superimposed ground glass opacification and consolidation. Consolidation only dilated vessels in the parenchymal zones that are affected, crazy paving, and organizing pneumonia pattern. These findings can be, or usually are, bilateral or unilateral in early phase, peripheral, multilobar, and usually they are basal and posterior. The examples: ground glass opacification, rounded in morphology, superimposed ground glass opacification and consolidation, consolidation only, dilated vessels, crazy paving, reverse towel sign, linear densities, perilobular densities. Uncommon features of COVID-19. Pneumonia are significant pleural effusion, lymphadenopathy, cavitation, and tree-in-bud nodules. If we see them, we should consider alternative diagnosis or superimposed diagnosis. With time, expect more complex patients with coexisting disease and overlapping findings. So, there are no specific findings for COVID-19 pneumonia, and the findings reflects pattern of acute lung injury, meaning organizing pneumonia pattern. There is a long list of differential diagnoses. Other viral pneumonias like influenza, atypical bacterial pneumonia, drug-induced, chemo and immunotherapy, organizing pneumonia, cryptogenic or secondary to infections, autoimmune disease, drug reactions, radiation therapy, illicit drug use, and finally acute interstitial pneumonia. Now, we'll talk about CT patterns of lung changes during the disease course. 4 stages were described based on lung CT findings during the disease time course in papers that were released in February. The early phase, from the onset of symptoms until the 4th day, the progressive phase, 5 to 8 days of symptoms, the peak phase, 2nd week, and absorption phase, 2nd week and later. In one of these studies released in February, it was clearly shown that ground glass opacification, in blue, were present during all disease course and peaking at the progressive phase. Here. The consolidation in yellow peaked later in the disease, and crazy paving appeared in early disease, although peaking at the progressive phase. Another study released in February showed that normal chest CT was present in more than 50% in early disease. It's here. Consolidation and bilateral disease were more frequent in progressive phase, and especially on the 2nd week of the disease. The peripheral distribution regarding consolidation and organizing pneumonia pattern were more frequent in 2nd week of the disease. And finally, linear opacities were more frequent in the late disease. Here I tried to resume the CT patterns of lung changes during the disease course. In yellow there is a timeline representing early phase, progressive phase, peak phase, absorption phase. Usually in this phase we see ground glass opacification or no findings at all. In progressive phase we'll see more ground glass opacification and some crazy paving, sometimes also ground glass opacification with superimposed consolidation. In the peak phase, we'll see more consolidation and also a mixed pattern and crazy paving and of course organizing pneumonia. In the absorption phase, we'll see the same findings but with a reduction in the number of lesions and involved lobes as well as a reduction in consolidation's density. During all the disease, we can see, or not, some bronchiectasis, and we can see dilated vessels in the parenchyma affected areas. The architectural distortion is more seen in late disease. We don't know what's happening here if there is a chronic phase with lung fibrosis. This is a resume of the typical progression of COVID-19 pneumonia. In first day, we'll see ground glass opacification with vascular structures very nicely depicted. They are enlarged, of course. In the first week, day 5, we'll see increased extension of disease, increased density, but still a ground glass opacification pattern. In second week, we'll see more density, consolidation pattern, and more extension of disease. And finally, second week of disease, we'll see organizing pneumonia pattern with linear opacities, perilobular densities, okay? And we'll see also a reduction in density of the consolidation and the extension of disease. It's here. The healing process sometimes brings some bronchiectasis and architectural distortion. This is a case from Faro Hospital, a male, 69 years old, with fever, dry cough, progressive dyspnea for 1 week. First X-ray in day 7, we'll see some ground glass opacification here, and we don't know, maybe here. In 2 days' time, it's clear that some consolidations are appearing here and here. And on the second week, bilateral and diffuse disease, more proeminent in inferior parts of lungs. Same patient, X-ray and CT scan, same day. We can see that the predominant pattern is crazy paving and very extensive disease. This is a male with 24 years old with fever, headache, dry cough, progressive dyspnea for 1 week. And we can see that in first week he has bilateral consolidations. A few days later he was sent to ICU with extensive disease, and in third week a good progression, and he is recovering from this disease. Okay, so let's move on to the correlation between the mechanisms of SARS-CoV-2 lung infection and imaging findings. After viral attachment via ACE2 in cellular and viral replication, there will be a cellular lesion, and of course there will be no findings in X-ray and chest CT. In pulmonary phase of disease, we'll have pneumocyte destruction, inflammatory reaction, and alveolitis, and also edema, and we'll see signs of pneumonia. groundless opacification, and consolidation with shortness of breath. The majority of patients will begin the repair with healing and will see patterns of organizing pneumonia. On CT and X-ray, we'll see the reduction density of consolidations with slow resolution, and the patient will have some respiratory symptoms. In a minority of patients, in a minority of patients In a minority of cases, this will progress to acute respiratory distress and systemic inflammatory responses syndrome, shock, cardiac failure, renal failure, etc. And we'll see findings consistent with ARDS. I would like to speak about the evolving role of chest CT on COVID-19 pneumonia since February to May 2020. In February, there was a paper released with 114 cases saying that chest CT has a high sensitivity for diagnosis of COVID-19 and is a primary tool for the current COVID-19 detection. In March 2020, most of the radiology colleges pronounced themselves against the use of CT as a primary tool for COVID-19 detection. On March, the RSNA published an article with a structured reporting for chest CT. We'll see it later. Also in March 2020, the Dutch Radiology Society proposed a CT report and also classifications for radiologists to use. Also in March 2020, our colleagues from Oporto in Hospital São João proposed a report. Our colleagues from Hospital São João in Oporto also proposed a structured report and a COVE score, very similar to CORADS. In April, the scientific papers released in February were reviewed, and it was not a good review because they said it was high risk of bias, and to date the radiology literature of COVID-19 has consisted of limited retrospective studies that do not substantiate the use of CT as a diagnostic test for COVID-19. Finally, in April 2020, the Fleschner Society came and published some consensus, a multinational consensus. Imaging is not indicated in patients with suspected and mild clinical features unless they are at risk of disease progression. Imaging is indicated in a patient with COVID-19 and worsening respiratory status, and also indicated for patients with moderate to severe features of COVID-19 regardless of COVID-19 test results. Daily chest radiographs are not indicated in stable intubated patients with COVID-19. CT is indicated in patients with functional impairment and or hypoxemia after recovery from COVID-19. COVID-19 testing is indicated in patients incidentally found to have findings suggestive of COVID-19 on a CT scan. Okay, and in April also, the European Society of Radiology and the European Society of Thorax Imaging published these recommendations that are very similar to these ones, okay? But we can also add that CT allows evaluation of disease extent at baseline, which may help to predict a poor outcome and need for ventilation, we should add an additional contrast enhanced CT scan if we see that the patient is not well and the findings of the CT are not so severe because there can be a pulmonary embolism, and repeat CTs are indicated in cases with suspected complications. Again, the European Society of Radiology proposed a structured report also, and finally, in late April, CURWAD's system were published. Okay, so let's see the structured reporting for chest CT on COVID-19 with cases illustration. I prefer the RSNA structured report because it has only 4 categories and it looks simpler than the other ones. So, typical findings, we know already what they are. They classified in typical findings, indeterminate findings, atypical findings, and negative findings for pneumonia. Let's check them. Typical findings for COVID-19. Example, round glass opacification, bilateral, multifocal, peripheral, and rounded. Typical. Another typical for COVID, peripheral, bilateral, ground glass opacification and consolidation, both of them, with some crazy paving here and here and here, and also findings of organizing pneumonia here. This is a case of typical COVID findings, ground glass opacification, peripheral, bilateral and multilobar, but with 4 RT-PCR negative tests. So remember, typical appearance of COVID-19 pneumonia cannot exclude other viral pneumonias, here, influenza pneumonia, neither organizing pneumonias, here. They are very similar. Indeterminate for COVID-19, we can see bilateral ground glass opacification with no specific distribution, non-rounded morphology. So we cannot say it's classic for COVID-19, but this patient, she had a PCR positive test. Another indeterminate for COVID-19 because there were unilateral ground glass opacification, peripheral with non-rounded morphology, so it was classified as indeterminate for COVID and PCR positive. Okay, another cases of indeterminate for COVID-19 of other diseases like drug toxicity and Pneumositis Pneumonia. We see widespread ground glass opacification, non-rounded morphology, and no specific distribution. Atypical for COVID-19, for example, and lobar isolated consolidation without ground glass opacification. We could think of a bacterial pneumonia, or this is a case of an atypical for COVID-19. We saw isolated consolidation without ground glass opacification, at least relevant ground glass opacification, but it was PCR positive. Other findings of atypical for COVID-19, cavitation and tree-in-bud nodules. Negative for pneumonia, no parenchymal abnormalities that could be consistent with infection. Specifically, ground glass opacification and consolidations are absent. A normal examination does not exclude SARS-CoV-2 infection. Finally, some pitfalls, Linear and subsegmental atelectasis here can be very similar to the organizing pattern of pneumonia, the linear opacities here. This is a COVID patient. This is only linear and subsegmental atelectasis in a normal non-COVID patient, Also, ground glass opacification can appear with poor inspiration effort. This is the same patient, supine and prone position, ground glass opacification in lung-dependent portions here and they disappear in prone position, and this is a COVID-19 positive patient. Okay, so we know that RT-PCR is the current gold standard for diagnosis. We should repeat this test if the clinical suspicion is high, because sensitivity is not so good and it's not always available, as we know. Chest CT has a reported sensibility very high, but it's controversial because studies had selection bias. We should also remind ourselves there is radiation exposure, and although although the scan time is short, the decontamination time is prolonged, 1 hour at least. Normal chest CT and X-ray cannot exclude infection, especially in recent onset of symptoms, and chest CT should not be performed as a screening test in patients with mild or no symptoms. Chest CT is currently being used for diagnostic purpose to guide management decisions in severe symptomatic patients, as well as in seriously ill patients, and PCR unavailable. We can use it also, or it's being used to rule out false negatives and in patients needing urgent treatment for other severe disease to raise staff level of protection. Chest CT is currently being used in positive RT-PCR patients to guide management decisions in hospitalized patients, to deal with complication and to consider alternative diagnosis. Chest radiography has a low sensitivity for GGO detection, ground glass opacification, but some studies showed that the baseline sensitivity up to 69%. It's used in many countries for triage purpose to signalize probable COVID-19 patients and to assess extension of disease. Chest radiography can be useful in hospitalized patients for assessing disease progression and suggesting alternative diagnostics, like bacterial superinfection, pneumothorax, and pleural effusion. Portable radiography units are advisable, and chest radiography should be performed within an infected patient isolation room or in the COVID ICU. It eliminates the risk of transmission, and it's particularly important in environments lacking PPE. Lung ultrasound is used as daily monitoring tool in critical care patients, has an excellent value when results are integrated by the scanning clinician into the clinical decision process, and it's appropriate and needed in pregnant women, in children, and in ICU. Ideally performed at bedside, avoiding patient transportation and contamination. As a potential triage and diagnostic tool, it needs validation, needs very well-trained doctors, and carries high risk of contamination. It has a greater sensibility comparing with X-ray, but doesn't allow differentiation between bacterial and viral pneumonia, neither pulmonary edema and lung infection. Doesn't allow as well a complete evaluation of lungs, so it can underestimate severity of lung involvement. Please, a message to radiologists and radiographers: in COVID-19 CT protocols, reduce radiation dose and field of view. Radiologists should report only findings of acute clinical relevance, and don't forget findings of prognostic value like emphysema or UIP pattern, and contact the doctor who asked for a CT scan if you have findings suggestive of COVID-19 in an unsuspected patient. Finally, a message to colleagues in emergency room: don't forget, when you ask for CT, to report the COVID-19 status, the duration of symptoms, as well as relevant relevant lab findings and any pre-existing chronic lung pathology. Message to all colleagues: during the peak, consider suspending all non-essential and non-emergent immunological exams to reduce the radiologists and radiographers' burden, to reduce the healthcare workers' infection, and to conserve PPE. And thank you.
Now, hello to everyone, and thanks all to be present. I think all of you are hearing me, yeah? Okay, but I'm not hearing you.
Can you hear me now?
Oh, hi, Mike. Now,
Hello,
thanks
hey.
a lot to be present. I know that probably you are everyone with a lot of work present. I think, yeah, you are hearing me, yeah?
Yes.
Yes, hi, Monica.
Hi.
And hi, Dr. Jorge.
Hi. Can you hear me now?
Oh, yeah, hi, Mike. Don't worry, I'll be doing my night shift, Dr. Jorge. And I know that probably you are everyone with a lot of work present. I think, yeah, you are hearing me, yeah? Okay, now to the people that are attending to the webinar, you may feel free to ask in the chat. Don't worry, I'll be doing my night shift question that you have that, in general or directly to each of the Monica or Dr. Jorge or Mike. Okay, and we'll try to answer as soon as possible and together if we have many questions and to put like in a general topic. And I want to know, how are you? Monica, is everything okay with you? I've been told that yesterday you had a little fall.
Yes, I'm okay now, but as you can see, my video was not quite perfect. I had no time, but I'm okay. Thank you.
No, but it was a clear presentation and a very good revision for us, no radiologists, and to understand better what are the strengths and the limits of the CT scan. And Dr. Jorge, everything okay in Braga? In the yeah, and I'll start with a small question because there is a paradox. What I've seen, I work in the department which you show the results, and I know by from my work what is happening. And there is a paradox that we improve in some of the complaints around the times of waiting times and so on. But what is worse now in the pandemics? We improve the numbers of the people that are coming to the emergency department, but there are other problems that changed with these pandemics, and in what sense?
I think that we've done something good, especially the things that the separation, the circuits of COVID and non-COVID. It was better for see the patients. We did that very early in the pandemic, so we did not mix the persons, and probably we did not make many persons get COVID in the hospital. So okay. It was a very good thing.
The cross infection, okay.
Yes, I think we minimized that very early in the beginning of the pandemic. Now I think the great fright is two things. First is the pandemic, the second wave of the pandemic probably is going to confound with the flu season. We probably in October or September we are going to have the two things around. It's not going to be very good. The flu season and the second wave of pandemic. And the second thing is fatigue and boredom. People are getting a little fatigued, do the same thing, the same fright, the same stress, and afterwards, if you do the same thing, it's boredom that install, and probably the risk is augmenting if you get boredom. So we have to do something to keep the people with sharp mind and see the risk, so you can have a low cross infection and the professional don't get the virus. So in our hospital, only 2 doctors of our team get the virus, so and probably not in the hospital. So I'm very glad with the care that you take of the professions, and at the same time a little worried about the probability of cross-infection, and if you get too bored, you probably make mistakes. And it's, in my mind, do something about that. I'm trying to think.
Yeah, thanks, Dr. Jorge, because you have to think very, very carefully what about the second waves of infection, and the life goes on, and we have to see other patients and so on. And I feel personally that the boredness and doing always the same tasks and so on, and the burnout between the professional school, like put down some of the strengths that we had at the beginning. But and then to hearing the other patients like questioning, should I go to the hospital or not? It will be safe or not? And for you, Dr. Jorge, do you think it's really safe to go if you have another problem and the circuits that are put in the hospital, they are really safe? Yes.
In the moment, I think there are, on the safe side, the risk is not always zero, but we are very safe, and I recommend that to the people, don't be afraid, because we have a very safe and sound system that separates the two things. So at the same time, as you see in our numbers, we have 50% of the persons that go even now at the hospital are non-urgent. So we have the same problem in Portugal, that non-urgent go into the emergency department. Even with 300 patients, half of them are not really urgent. So we have the same thing because you are in Portugal, but it's safe. I think the myocardial infarction and a stroke could go to the hospital to have a nice treatment with our professionals.
And Dr. Jorge, what was any problem related with the radiology department, not of discussion between colleagues and so on, but saying what were the main problems to put the circuits for the exams, namely the CT scan?
I think the principal problem was the fear.
Was between the professionals and
between, especially in the professional, the radiologists and the radiologist technicians, they were very afraid. So we have to make many meetings to break the fear apart. And as you see, the numbers were very low of the CTs. Okay. and the ultrasonography made by the emergency department, the radiology department. But the principal thing to do was make the fear disappear with the sound science and the prophylactic measures and the cleaning and the separating. I think we solved that at the moment. We're not afraid anymore. We are just the right amount of fear to make things go right.
And thanks a lot, Dr. Jorge. And Mike, everything okay with you?
Going well, yes. And for us, the COVID numbers are starting to drop, fortunately. So that is a good relief, but we're encountering the same problems where strokes are sitting at home, myocardial infarctions, and chronically ill patients are deteriorating but are afraid to come in or can't get access to transportation. So I think similar things.
Okay. And Mike, what do you think in a system that, like in Portugal, that we are not really like with a point-of-care ultrasound program installed in every hospital? What are the main challenge that a modern hospital now, if we would like to put a system with point-of-care ultrasound, and namely for the second wave of infections, for you, what will be the next steps they should do? Imagine now for September, October, an hospital that, I want to put the ultrasound in triage and put the system to help better triage the patients and to monitor the patients. What do you think? Probably this is a very hard question to answer in only 1 minute or.
It's very simple to answer, harder to execute. I think the key is good planning, organization, and execution. That means there have to be standards put up, that are not too difficult, easy to comply with. The beauty is you could focus quite narrowly on just lung ultrasound instead of every department trying to tackle every aspect of point-of-care ultrasound, and that would make it easier to train larger numbers of physicians and also to have everyone stick to the same criteria. But the time to plan is now, and the time to organize is now.
Okay. And what do you think that is like the learning curve to learn the basics to have like some doctors, I don't know, because we have tents outside the hospital, you know, and sometimes these patients need to be triaged quickly, and some of them are sent home without being able to do an X-ray or something. That's impossible. Or if they feel that they need some complementary exam, it's complicated because they have to enter in another system of the hospital. I think in those parts, like tents that are outside the hospital, the ultrasound could be very helpful. How many times do you think it's necessary to train someone and to safely could have like to put some protocols on with lung ultrasound? Or if there is any data that could orient the administrators and the people that are running on those places?
The data that we have on learning curves is limited, but suggests that about 25 examinations after initial training, expertise starts to plateau a little bit. The key is to make sure that there's enough pathology exposure in those 25. Of particular difficulty with lung ultrasound is lung ultrasound in a normal patient is always very boring, very similar. It's important, though, to be able to recognize different artifacts and create a total lung picture of the pathology or abnormalities, and then integrate this into clinical decision making. And for this, protocols are very important, and probably we want to make sure that everything is very protocol driven, so that people have good reference cards to look at to see, is this finding normal or abnormal, and then trace down from there as to what it may mean for the differential diagnosis, and then let their clinical judgment take it from there.
Okay. Now, Mike, I have some questions that are from our attendants of the webinars. This is Tiago Veiga, my great friend, our friend, and he's also from the study group of ultrasound. He is really an intensivist and an enthusiast of point-of-care ultrasound, which I know he uses every day, monitoring and doing ultrasound in critical care patients. And he has like a question for you, and I don't know if Monica, if she has some opinion, she also can answer. And do you think that lung ultrasound score is a good predictor of loss of lung compliance, or is it somewhat blunt to stratify patients into well-defined risk groups? What do you think?
I think for my part, I think we need more data on that, and ideally data that's generated from a lot of the retrospective data we'll be able to analyze and others in the next 6 months, and then somehow have a prospective validation. My personal suspicion is it is a good indicator. This is a good study when it's put together in total, and especially with other physical examination findings and clinical data. But that is just my suspicion from reading what's out there, from scanning about 35 COVID-19 patients and another 30 or 40 that were negative. But that all needs to be validated. And we also have to be very careful. What works in the hands of lung ultrasound experts may not work as well in the rank and file providers on the front lines. And it's really to benefit them that we want to do things because they will benefit many more patients than any few experts. So I think some more work is ahead of us.
Yeah, Mike, you stressed on that, and I've been talking with some of these aspects with Monica, and I think Monica totally agree with you, because some of the aspects of ultrasound need so many subtleties that we really need a really good training. Even I can talk properly about lung ultrasound because I'm doing regularly like for 6 years, and even after these 6 years doing almost every day lung ultrasound with the COVID-19 and with some strange case that appeared in front of me, and I really have doubts. I imagine if we start to do like with a 6-month or 3-month training, I think this is to put all this together with those scars that you talk I don't know, but a strong communication between the experts and the less experts. Thanks. And Monica, I have a doubt that is a general doubts that are because I'm not a radiologist. What will you think in the second waves of infection in the next month or even years? What will be like the confounders of the sequels of like the scars that could like the COVID-19 have on the patients? I know that for years we have been taught in the university to see like the old scars of tuberculosis and so on. And now we will have like from COVID-19. Do you think that will be really a problem or there is no data and we don't even know because it's too early to analyze the problem? Or in part, if we can compare with other viruses, there is any evidence that from flu, from influenza, from pneumonia, for other viruses, then there is a scar that we'll see in the next CT scans?
Well, too many questions.
Yeah.
I think, well, we have no data, that's for sure, but we can say that patients that have severe disease will probably have some sequela. And we can say that the organizing pattern that we see, it's like the healing process surely will leave some bronchiectasis, some fibrosis. Anyway, that could be reversible. We don't know yet. It will be nice to see a study calling these severe patients to the hospital again and perform CT scan if they have prior CTs to compare at 3 months' time or 6 months' time anyway, and maybe even with ultrasound also. I would like to see that. Calling them again, the severe patients, to do a CT scan and an ultrasound, a lung ultrasound. I think the future will tell us.
Monica, I will, as a coordinator of the study group and you a board member of the Portuguese Society of Radiology and Neuroradiology, I think this will be a good topic to work together, and who knows, and we can put like those things running on, and even with other countries. And I think that will be a good idea. I will pick that topic, and let's see if we could put a perspective now, like seeing the afterwards of the pandemics. Now we have many questions from our attendees. I will ask more patients for you. Mike, everything with you? Time, if you have time? Yeah, okay. No, I have to work. My night shift will start like in 45 minutes. Dr. Jorge, don't worry. I'm 4 minutes in my Vespa to the hospital. And José Pedro, our great friend, he's a surgeon, but as a surgeon, he's a very worried doctor, and who does the ultrasound, mainly the IFAS protocol and so on. And he's asking like a very sensitive question: that what are the tip and tricks to disinfection and to try to not to have cross infection? I will ask like briefly to Mike and then Monica. I have my opinion and my experience and what I'm doing in Braga. but I will ask to Mike. Mike, any tips you may highlight to the problem of disinfection?
For me, in my setting, I've had to use the smallest machine possible, the most portable. Luckily, I have access to a handheld device, and literally before and after every patient, I wipe it down every millimeter, including the transducer, the cord, all of the control surfaces, front and back of the tablet, with the hospital supplied antiseptic wipes that are approved for COVID-19. And I actually use a double glove method where I discard the initial gloves after a partial wipe down, and then go to the second pair of gloves underneath and continue wiping down. I've even filmed it, and I've not seen any areas where I could leave something without proper disinfection, and make sure to do that very regularly. It's much harder with a larger machine, and that's where we see people covering large portions of it with plastic bags to protect it. But then there's even the issue of having to clean the wheels on larger equipment. But not everyone has the luxury of having a very portable machine or a choice of machines.
Thanks, Mike. And Monica, if you have any tip, or even I know that you don't have experience now with ultrasound with COVID-19 patients, but we have not to forget that we were doing ultrasound a lot of times with patients with indications for isolation, like with the Staphylococcus aureus methicillin resistant and the Acinetobacter and so on. And even when we go to the critical care, probably you were like called a lot of times to go to the intensive care and patients that were isolated. And do you have any tip or what do you think are the main problems to talk about disinfection when you are using ultrasound?
Well, in Portugal, there's a big problem because we don't have a culture of doing things like a protocol. Okay, so my advice is to always have a second observer, just to see what are you doing, if you are doing correct or not, and to help you with your imperfections. I'm a little bit worried in Portugal because we don't have those kind of machines, not portable. Everything is big and with wheels, etc. And it's going to be a real problem. We cover everything with plastic, but that's not enough. It's really difficult, and we don't know which patients have COVID. In a few months' time, it will be a mess. We don't know if they are infected or not, and we assume that some have COVID and some don't have, but I'm sure that in those patients that we don't suspect, there will be positive, and we are not wiping the ultrasound machines like Mike, just a quick wiping. So I think that's our biggest problem, is the second wave and the mixing of the patients. So I'm sorry, I have no solutions for that.
Yeah, but I think we have to discuss, and we as representing societies and groups of enthusiasts, we have to endorse like the society and to put like some orientations and to discuss. I think this is a good topic to talk in the future. I've been working with the Brazilian Medical Society with our friend Tiago Santos, and we will talk in next Saturday. And we have been talking a lot with the Canadians and so on. And we have like a small guidelines and like in cards and to help people. But I think you, Mike and Monica, you said a very important topic, and I will talk about my experience. To record or to two people sing, because the other sing the other and telling, look, that corner that was not, or do you have many things in the top of the machine you don't need, and then to have like to think before. I know that it's very difficult, and when we relax, when we'll be relaxed, it will be like, it will, the first one that appear, we didn't know about infection, but then it will impact on you. You will have time then to put all the things again, because the risk zero doesn't exist, okay? And I have a portable machine that is a Sonosite, and I think she's very cool, and an Edge too, because he has all the surface that are easy to clean. And the work was to put in a car, or like that was the most simple as possible, and the smooth surface to be easy to clean. And I try always to tell to my other colleague, please, can you watch me doing the ultrasound exam to see if I'm doing something wrong, and if I went through any topic that I should have done or something, okay? I think this is a very good topic. Now we are getting short of time. I will only ask you to wait a bit. We will launch now a small question in the end of all our presentations and discussion that to be answered in the site to people that are watching now the webinar. It's a small question, and then we'll have the, okay. It's a small question, and then we'll have the, okay. I know our technical supporters, Tiago, I don't know, could you give us the results? And the, okay. We have only one vote. I think the people are, no, our technical supporters, Tiago. And the question is simple. Do you, yeah, the question is that, do you expect to use ultrasound in the future for patients with COVID-19? Okay, this is like a basic survey of our attendants, and that if after hearing us and they feel like enthusiasmated and to do ultrasound in COVID-19 patients, but only one vote. It was not me, okay? 2 votes, and let's vote even to say no. Then 4 votes for now. And we have like a survey that we did before the COVID-19, and we want to show the results the 2nd of May for our first meeting. And we had more than 300 answers, and it was quite for our surprises, because I thought that we will have like less people trying to do point-of-care ultrasound in Portugal. I was thinking that the scenario will be bleak, but it's not like so bad. We have a lot of enthusiasts, but. And as Monica agreed with me, we have to have like small steps and very solid ones, and to talk before with everyone in every society, and to see what will be like the next steps to put like the point-of-care ultrasound in really in the right place. And we have 4 votes. And all the 4 attendants said yes, okay. I don't know. We are 100% enthusiastic after our webinar, and I think we are reaching the end. And first of all, I have to thanks again to the Portuguese Society of Internal Medicine, to Fujifilm Sonosite, who are our sponsors, and of course to thanks Dr. Jorge, Monica, and Mike, and thank you. I don't know if you have any final message to give.
Well, I would like to thank you for inviting me, and I'm sorry for my talk was not perfect. And again, thank you, Dr. Mike. It was inspiring, and I hope this will be the first step to come together with radiologists and non-radiologists practicing ultrasound in Portugal, of course.
Thank you, Monica. Thank you, and I'm sure that is not would be the last opportunity to do that, and we're lifting the restrictions and so on, and who knows, I don't know if it will be probably not 2020 a physical meeting, but in 2021 maybe. For sure we have to do our first meeting and physically. Okay.
Okay, thank you,
Mike. Thank you again. I know you have to drive a big distance now to home, okay? And thank you, because I know that the traveling by plane now in the United States is very difficult, and you had to go to Seattle and you live in the other part of the United States. For us, it's like going from Lisbon to Moscow. And yeah, it's really the same thing. It's amazing what in the United States the distance and for working you have to do. We Europeans are like very cozy in our houses, okay? And thanks a lot.
You're much more efficient.
Yeah. And for your effort, because I know that it was very difficult to be on. And then to Dr. Jorge, and thank you. You are like an inspiration also, and I'm very honored to work in Braga, because really the organization and our leaders in every department, from radiology, from even the people that clean the rooms and so on, we work together, and it's because that I think we have a very low number of cross-infections between professionals and even between the patients, and it's a great effort. And as Dr. Jorge said, we have now to be strong to put this on for a long time, and we have to see complementary ways to the burnout don't relax us and have like an increase in cross infections. Let's final this, and next Saturday will be the third webinar with Robert Arntfield from Canada, Tiago Santos from Brazil, Costantino from Italy, and Yale from Spain. You all know these combatants from the other webinar, and our special guest is Robert Arntfield, that at the end will moderate, and we'll try to do a reflection what was the last 5 weeks working with COVID-19 patients and focusing more in clinical aspects, and I hope you'll enjoy it. And now let's bye.
Okay. Bye, thank you. Bye. Drive safely.
Bye.
Yeah, drive safely.
Ciao. Take care.
Pronto. Oh, Mônica, a tua apresentação estava espetacular.